Can you hear me in that back corner? I see a large contingent of MUSC back there. I did shower, so no fears of those you want to sit on this side. Today we're going to talk about hemodynamic instability and some of the controversies generated around fluids versus vasopressors for intraoperative management. And it's remarkable that this is an old illustration of the Lincoln-Douglas debates. And William T. Morton, famous for his ether dome demonstration in a town just north of New Haven, was a contemporary of Lincoln and Douglas. And in the 150 years since that debate, we still had plenty of political debates, as we saw this year. And really, anesthesia has kind of gone along the same path, too. Despite 150 years of progress in monitoring, drugs, education, anesthesia as a whole kind of remains very much what I call a dirty sport. We have a number of issues, a number of complications that are still quite prevalent both in our cardiac and non-cardiac surgery patients. And hypotension is probably the most common one we face. And the debate about how best to manage hypotension has really continued for a long time, as well as its incidence. In the old days, you can see right behind the debaters, they'd have this kind of august panel. You can see kind of a young Ronald Reagan right here, back in the 1840s. And they would kind of decide, the matters at hand. And, medicine's kind of taken the same tack, if you think about it. We have all these consensus panels. The residents who were at the session last night, we talked about some of the ACC guidelines. But really, there's a whole host of these consensus panels to help us better manage things. And we had this fluid debate, and I turned to Dr. Reeves. I said, Scott, what we need is a consensus panel that kind of, and an international one as well, so we don't have European standards, Asian standards, American standards. And Scott said, Al, let's do it. So I want to show you, we put together a panel at last year's meeting to resolve this issue. And here's the panelists that I've chosen. Simon Cowell, Paula, Randy are all from the American Idol group, and they've been very gracious to take on this debate. And when it comes to fluid management, there's really two American Idolist finalists. And it's these two gentlemen right here. Francis Moore, who was a former chair of the Peter Bent Brigham Hospital Department of Surgery back in the 60s. He was a strict conservative regarding fluids. And his competitor was Thomas Shires from the University of Texas Southwestern in Dallas. And Tom Shires has been known as a great liberalizer of fluid management. Now, I said I'm going to try to provide some political context for you folks here today. So I've kind of color-coded things here. So this is the conservatives, red states here. Here's the liberals, blue states. But, the observant clinicians that we have trained here, I think can obviously pick this out even without the color coding. Take a look at Dr. Moore's background he chose for his photo. He doesn't like a lot of fluids, kind of dry papers, books. And look at Tom Shires. The report has there's never a fluid that he didn't like, and that tells you a little bit. What about their policies? Well, the more conservative policy was based on the following thinking, that the surgical stress response that happens during surgery releases aldosterone and ADH. These two hormones do what? They cause salt and water retention, and that in itself leads to excessive fluids, and therefore we need to fluid restrict. Let me get rid of this guy here. Results in a clinical management that the patient should be fluid restricted. That was Moore's whole thinking. Shires had a much different thought. His feeling was that the main consequence of surgery was a loss of intravascular fluids, going to what he called this kind of new concept of the third space. Because of this, that's why patients were reducing aldosterone and ADH, and therefore the proper treatment and management of surgical patients was to give fluids. Now, this debate happened in the 60s, and anyone who follows political history in the 60s knows that the liberals really had their way, and that was the case here. And let me show you some of the data. And this is the most quoted paper by the Shires groups on which was going to be the basis of fluid management really for the next 50 years in anesthesia. So like most surgical studies, it's a very large patient group. You see they were able to find 12 of them to participate. The Shires group used a radioactive sodium tracer, and this would kind of follow the fluid in the extracellular space. What were the results? Well, we found that there was a 1,600 cc drop in extracellular fluid volume, supporting his claim that patients were losing fluids during surgery, and that this ECF drop correlated to the degree of trauma. So the more trauma you had, the more drop in fluid. When you read the paper, there's no data to support that claim at all, but that was their feeling. I want you to be aware of a couple of facts. First, in this study, these patients received no IV fluids, none the night before, none otherwise during the case. So they basically were NPO and without IV fluids, and that blood loss typically exceeded 1 unit during the case. So when you look at this 1,600 cc's, it's really not that impressive, again, when you consider blood loss and just the need for maintenance fluids. Does the surgery itself really make a difference? Well, 20-something years later, Schreier's and group are still at it. Here they're going to actually kind of do a little bit of a test where they're going to take two groups. One they're going to treat with fluids. They took a whole 5 patients here, the liberal group. And the other one they're going to continue with that restricted plan I told you about before. They're going to get very little fluids during the case. So what do you find? Well, if you give them no fluids, surprise, surprise, you're down about 1,600 to 1,900 cc's. And if you give them 1,600 cc's, their extracellular fluid volume remained pretty close to normal. But again, take a look at this data. They had a lot of blood loss that wasn't accounted for, and they had no maintenance fluids. And when you add in those two factors, again, I don't see much of a cause for a lot of fluids being required in these patients above the maintenance fluids and above what they'd need for blood replacement. But many individuals took the data into a much different context, and certainly many folks who were constrained by this conservative dictum, now free from it, I think became kind of wantonly excessive with fluid administration. And this is a paper from the UK where you see the admonition for 15 cc's per kilo per hour fluid. And you'll see these kind of things in your textbooks, major surgery, abdominal surgery, et cetera, where you give these 10, 15 cc's per kilo per hour to account for third space losses. Again, let's look at the data for this. Now we've got 6 patients in each group. We don't bother to randomize them. The researchers weren't blinded. They're giving halothane for colon resection, a little out of context, I think, for modern anesthetic care. And what they found is the difference between giving 15 cc's per kilo per hour and 10 cc's per kilo per hour was that the blood pressure was higher in the 15 cc per kilo hour group. However, they never looked at any outcomes in the study to show that this was better, worse, or indifferent in these patients. And really, there is no data to support these kind of fluid administrations. No one's really looked at an outcomes issues for those fluid administration protocols. Now, you know, in politics, we've got these dynasties. I don't know if you've seen like the Clinton family. You know, you get one after another. The Bushes, they continue year after year. Take a look at this. Here we are in 1983, 20 years later. We've got Shire's 3 now, you know, kind of promoting the same kind of fluid dogma. And I showed this paper not only because of that, because it's one of the first papers you'll see looking at PA catheters. So they put PA catheters, and the goal of this study was going to keep the PA catheters numbers the same and compare giving fluids either by colloids or by crystalloids. So here we see the Ringer's lactate in the speckled, and in the lighter color we got a colloidal solution. And what they found is that, boy, we need to give a lot of intraop fluid in these patients, these are aortic surgeries, to keep their PA catheter numbers the same. We're talking like 17 cc's per kilo per hour here. And actually needed a lot less colloid to do the same, which I thought was interesting, and we'll talk about that in a second. But you can see how these families can kind of continue on their political agenda, and it made me almost wonder, was this some kind of vast, you know, left-wing conspiracy here to liberalize fluids? And I was thinking about this, and it happened, you know, I was watching college football, you know, a couple of months ago, and this is when it really became obvious to me that that was something to think about. How do I minimize this to get the movie? No, it's on this computer. Yeah, switch these computers, right? We got a technical wizard here. We got one going screen. Yeah, okay. You got volume?
This is a ballast tank. They fill these up to keep the ship stable. That valve right there leads to the tank next door. That may be our way through.
Maybe what other way
Wait a
is
minute,
there?
it's a pressure valve. It won't open unless there's tremendous pressure.
Oh, don't tell us we're trapped.
No, it'll open.
How?
By flooding this entire tank.
Dr. Schreiers.
Exactly. Okay, everybody back away. Get back.
Crazy!
Here we go. And here comes
This is the Texas tortoise right here. That's confusing. And now it's time for the ICU. If you can switch me back, that'd be great. So, how to go about improving fluid management in the OR? Well, I think the first attraction for us was to use improved monitoring. Thank you. Yeah. Was to look at using improved monitoring. And of those, the PA catheter was certainly one that we looked at. And I want to show you some studies on the PA catheter for the next few minutes and show how it can help us with fluid management. Do you guys have PA catheters here? Yeah. This study I show because it has very little bias about PA catheters, because the study wasn't about PA catheters at all. This was a study done in the 90s by a Canadian group. They wanted to try to show that the use of epidural anesthesia along with general for vascular surgery improved outcome versus general anesthesia alone. And to do that, they had to keep the management of the two groups consistent, and they used a PA catheter to do that. And here's their fluid protocol. So they're going to monitor the PA catheter and A-line, right? That's about the best as we do, right, for most difficult cases. What are we going to do with the PA catheter? We're going to maintain hemodynamics within 20%, maintain pulmonary occlusion pressure 8 to 12 millimeters of mercury, maintain stroke volume greater than 1 cc per kilo, right, like apple pie. And if it gets below, they're going to give crystalloid blood. So this is the kind of stuff I was trained on. This is how you do state-of-the-art practice. Well, what happened in this study? Well, we take a look at it. Here's the general anesthesia group. Here's the epidural group. The numbers are no difference between the groups. What stands out here, take a look at the crystalloid volumes they end up giving to keep those numbers as along that protocol. They ended up giving 17 cc's per kilo per hour, right, just to keep those PA catheters there. And look at the urine output. It's 400 cc's an hour. It's markedly excessive. And this is the type of things typically, you do an aortic surgery, you will dump in a bunch of liters of fluid, and this is what these end up. Now, how did it affect outcome in this group? Well, they were disappointed. They weren't able to find any difference in outcome, surprisingly, between the epidural group and the general group. But look at the complication rate. Congestive heart failure. 10% of the patients, 1 out of 10 patients in this state-of-the-art medical care of the United States, or actually this is Canada, ended up with congestive heart failure. How about prolonged ventilation? You got like 13, 14% of the patients with prolonged ventilation. So I must admit that really any differences between general anesthesia and epidural technique were probably washed away by the flood of fluids they gave during this protocol. And it's a protocol that's very similar to how we treat most of our patients using invasive monitoring. And in fact, a number of studies have looked at the PA catheter and its utility for intraoperative care. Perhaps one of the most widely quoted is this one that came out just a few years back by Sandem. Looked at the use of PA catheters in high-risk surgical patients. These were non-cardiac surgeries. They used a protocol-driven trial. What was the protocol? They're going to put the PA catheter prior to surgery. They're going to follow O2 delivery, cardiac index, occlusion pressure, all the stuff that we do. And what are they going to do? They're going to treat it with fluids, inotropes, vasoactives, right? Well, what happens in this trial? Randomized trial. Well, the treatment group, the PA catheter group, got more fluids, vasotropes, and inotropes as well. But you know what? There was no difference in mortality and no difference in cardiac events. The PA catheter was distinctly unhelpful for them in reducing morbidity and mortality in this large study. And several other studies have also confirmed this as well. Now, why are we having problems with PA catheter? Well, many people think that the reason the PA catheter is not working has nothing to do with the tool itself, but has to do with you folks who just don't know how to use this sophisticated device. Now, PA catheter is basically a waveform transducer. We look at the pressures. I don't think it's particularly difficult to do. And I think with a limited amount of training, most people actually do quite a good job. And I think it's difficult to say that the people doing these studies, who are all highly trained in the protocol, their lack of ability to use the PA catheter was the reason why they weren't able to get good results for it. In fact, I think there's a lot easier explanation for why the PA catheter data has been so unremarkable. And the reason for that is, if you look at over a dozen studies now that have been done in the perioperative period looking at CVP and wedge pressure, PA pressures, they all show that these pressures fail to correlate with left ventricular end diastolic volume, which is kind of a gold standard for preload. They fail to correlate with stroke volume, a gold standard for systolic performance. And they fail to even track changes in fluid status. So I think perhaps one of the reasons we're having problems with fluids, despite invasive monitoring, is that these PA catheters may not be as helpful as they can be. So let me show you, I got time for showing quick two studies here. I'll show you an old one. This is by Robert Hansen, which I like because it was one of the first studies to look at PA catheters compared to an emerging technology at that time, which is transesophageal echo, something near and dear to my heart. These are cardiac surgery patients after cardiac pulmonary bypass. And he looked to compare wedge pressure with LV end diastolic volume index. Now, what we should see, this is tracking changes now, right? We'd like to see data grouped in the lower left and upper right-hand corner if it tracked changes. And you can see there's no relationship at all between these data points in cardiac surgery. So everyone had to scratch their heads, well, what could it be? Well, we can't blame it on the doctor, so this must be a patient problem. And they blame it on, that changes in LV compliance, because we're looking at a pressure-volume relationship here, so changes in compliance due to autonomic tone, anesthetic depth, tachycardia, ischemia may be causing these poor relationships. Okay, sounds good. So it's not good when we really need it. How about in the healthy patients? Well, take a look at this study from Kumar, just in 2004. We're going to take 44 healthy volunteers. These are college kids off of the streets of Chicago, right? 12 of them are going to buy themselves PA catheters and nuclear scans. Another group is also going to get echocardiography, and he's going to give the same intervention that Holte gave. He's going to give 3 liters bolus, and we're going to look at the changes in cardiac performance with that bolus. Well, here's the data. At baseline, the PA catheter did not correlate with LV, EDV, or stroke volume. Take a look at the data. Here's stroke volume index, CVP. Horrible. Here's pulmonary wedge pressure, stroke volume index. You see any relationship here? I'm still looking for it. I think I found a little dipper. You see that? That's about all I could write here on this study, but they found a little dipper, so that's interesting, and we'll take that somewhere. How about if we look for tracking changes, which all my residents kind of justify using this. So doctor, we're going to track the changes in the CVP. The number really doesn't matter. Okay. Well, here's tracking changes. Here's stroke volume index. Here's CVP. I don't see it again. What do you guys see here? You see it? The dipper's back. I'm telling you, there's something to this dipper. So that's the only utility I've found for the PA catheter is, maybe for looking at the stars. Just to show that his data is not completely junk. When he looked at stroke volume index and the echocardiography numbers, and you found that what? You found a very tight relationship. This is what the data should look like. You increase your preload, you increase your stroke volume in healthy patients. So it really shows, I think, there's some serious limitations to PA catheters using to judge our fluid status. So what to do? Well, it's interesting. A bunch of people have taken what I thought was a very retro approach, very unlike this century. They've gone back to considering using fluid restriction in these patients. So instead of, try to avoid the excess fluids, and there's been a bunch of randomized clinical trials now looking at intravenous fluid restriction in non-cardiac surgery. And I'll just show you a couple of them here in esophageal surgery, abdominal bowel surgery, another one on esophagectomy. But the study, the article that caught my attention the most really wasn't even a study. It was this paper here. It came out as part of a pro-con in A&A last year. And the pro was fluid restriction in cardiac patients for non-cardiac surgery is beneficial. Okay. But take a look who wrote this paper. See this, William Johnson? I don't even know Bill. Look where he's from. UT Southwestern. That's Shire's place. I said, jeepers, I can't believe that. If UT South... Oh, alarm. Excuse me. If Dallas is converted, geez, the whole country's going to fall. That would be like Boston electing a Republican, for their city Congress. So I called Bill up. I called down there. Ding, ding, ding. Dr. Mr. Johnson. Dr. Johnson no longer works here. So you got to be very careful what you say on these political things, because you can lose your office. I think he's supposed to come to the SCA meeting this year, Scott, so we'll have to see how he's doing after this. But that was a courageous move on his part. Let me show you what I mean by restrictive patterns, what people have been doing, so you can get a sense of how it differs than maybe your current practice. This is a study by Brandstrup's group. Here's the standard regimen. Here's their program. So in a standard regimen, let's say you're going to give an epidural. What do? Usually give some fluids, right? They gave 500 cc's of Hespan. Restricted group, you get nothing. Okay? Third space losses. Well, you usually have these complicated formulas. You guys have seen these? You read the textbooks, you give like 7 cc's and 5 and 4, then you kind of adjust it during the case. They did that. The restricted group, got nothing. How about for fasting? They got about the same, 500 cc's of fluid. But more importantly, for blood loss, this is what I was trained on. We give that 3 to 1. 3 times the volume of crystalloid for every unit of blood loss. They did that, the 3 to 1 thing. How about for the restricted group? You get volume to volume, 1 to 1 using Hespan, until the patients needed blood. All right, so what happened with these patients? Kidneys curl up. They all die of hypotension. Well, here's the data. Here's the fluid administration between the two groups. Restricted is the R. Here's the control group, the S. And you can see that the control group got a lot more fluids. You can see the extra 4 liters of fluids. And you can see the weight gain here, about 4 kilos, just as expected difference between the two groups. How are the outcomes? Well, every outcome they looked at, and again, this is a blinded assessment, unlike the Liberals trials. It's a blinded assessment. All the complications were higher in the standard group, including major complications, minor complications, tissue healing, thought to due to a lot of infiltration of fluids into the wound, and cardiopulmonary complications, probably congestive heart failure, that kind of stuff. All better in the restricted group. So, is this fluid restriction a way to kind of right the anesthesia ship as far as palliative care? I think it's probably going to play a very important role. We need to get some more data on it in broader patient groups. But clearly it seems to be a trend that we're going to see more of. But it's going to raise the question, how are we going to manage hypotension then if dumping, 2, 3, 4 liters of fluid is not going to be our first option? And, one of the things we got to think about is this little word, vasopressors. Now, how many people here have used vasopressors in the OR? Okay, leave your hand up. Now, how many people have given a vasopressor and distinctly not told the surgeon you were giving them? Right, very common, because this is a dirty word, right? It's dirty. This is a dirty drug. Now, why is that? Well, everyone knows that vasopressors are bad. Why? Because they create right heart failure, right? They constrict down. It's a volume, can't handle the pressure. The RV blows up. Increases myocardial work, strains the LV, leads to ischemia. And, of course, it's going to make the kidneys curdle, the gut's going to dry up, and you're going to have regional ischemia. So I think it's kind of right for many to concern that we're going to look like this guy. Every time we give an injection, we try to kind of pull the drapes up and slip the meds in. But what's the data say about perioperative use of vasopressors? Are we right to give these, or are the surgeons really correct that these are probably a sign of bad care? Well, let's start with the right heart. Ken Tuman did a nice little study looking at the effects of phenylephrine versus volume loading on right ventricular function. These are patients undergoing myocardial revascularization. They all have right coronary artery lesions. None of them had really bad EF, but most of the EFs were in the 35 to 45 range, so some impairment. So how's the study going to work? Well, they're going to do their induction. When the blood pressure drops by 20%, they're going to give a bolus of phenylephrine enough to reach a target of raising the blood pressure 20% above baseline. So we're going to give, we're not talking like 50 mics, we're going to give a good amount of phenylephrine and drop here to get the pressure up. And they're going to compare the results they got with that to a fluid bolus they did at a later time in the case. So let's take a look what happens. Well, you can see phenylephrine was much more effective at getting the pressure up than the fluid boluses. And it did it how? Not surprising, by increasing SVR, really, which doesn't change much with fluids. But how about the right heart function? Well, stroke work went up in both groups. Stroke volume went up in both groups. Stroke work also went up in both groups. And look at EF. There was no change in the F in either groups. Matter of fact, the Tuman concluded that phenylephrine was a much more effective way to raise blood pressure per unit dilatation of the right ventricle. So it actually created less harm to the RV than the fluid boluses, which were leading to dilation. And that concern about RV dilation has really become prominent in the literature. And just to give you kind of an illustration of the concern here, what happens when you get acute RV failure and the effects of fluids. A problem with fluids with the right ventricle is this. Instead of just being kind of a passive conduit that we can just load up with fluids and hope it's going to push it into the left atrium, what happens is when you give a bunch of fluids, that RV-free wall is going to get pushed out. It's dilated. It's going to be under increased strain, and it's going to get increased risk for ischemia because of that increased strain. The second problem you run into is that the interventricular septum is going to get pushed towards the LV. Now that creates a problem not much for the RV, but really for this left ventricle now, which can't fill well. Its LV end diastolic pressure is going to go up. It can't fill well, so its stroke volume goes down. So you get more hypotension, more RV ischemia. You also get increased LA pressures from this because it's creating diastolic dysfunction, and now you put the patient at risk for pulmonary edema and congestive heart failure. So fluids are not a benign choice, particularly for the right ventricle. It doesn't like them much at all. And I'm going to show you another study. This is a laboratory study that compared fluids versus vasopressors, in this case norepi, for acute right heart failure. So here's our numbers at baseline, right? And they're going to create heart failure by increasing that PVR. When you increase the PVR, what happens? Cardiac output comes down. Your pressure comes down. Right? Things aren't looking too good. The RV-EDP goes way up. Let's treat that with fluids to try to improve that right ventricular function. Well, look what happens to your cardiac output when you give fluids in this RV failure model. It goes down. Pressure goes down. As I said, you're going to get RV ischemia with this. And that's what they found in this study. And the LV-EDP goes up and the left heart. So you get kind of the worst combination possible. Now, if you give norepi at this point, notice we got improvements in cardiac output, mean arterial pressure. Look at the RV-EDP come down and the LV-EDP come down. So again, when you look at the right heart, the data really supports the use of vasopressors compared to fluids for acute management. All right, how about the left heart? Does the extra work done by vasopressors really bad for left heart? I've been called, I can't tell how many times I've been contacted by other universities for consultations. A case goes bad in the heart room, and they see in the chart that the anesthesiologist gave phenylephrine for this acute ischemic event or whatever, and they were getting chastised by cardiologists or board reviews that wasn't really appropriate to manage someone with left heart problems. Well, the way I think this pressure volume loop is one of the nicest ways to look at myocardial energetics. And in a pressure volume loop, if you look here, we start with here's our LV volumes, here's our LV pressures. It fills during diastole, and the mitral valve closes, the left ventricular contracts. You get a big increase in pressure. Aortic valve opens. We get the systolic ejection phase, and then filling starts again, and this kind of goes around. And there's a couple of interesting points with these pressure volume loops. Notice that you can create a series of these loops by increasing preload. So as you increase preload, what happens? Well, the end systolic pressure increases, right? And you can get this kind of slope here can be drawn, the end systolic pressure relationship or the systolic elastance. The steeper the slope, the better your ventricle. So it's kind of a load-independent measure of contractility. Okay, so that's kind of nice. There's another one we can get here, which is this ratio of the stroke volume, see it here, and the systolic pressure. And that's your arterial elastance. It's kind of a correlate to, your arterial resistance. So we got the two of them. So we got systolic, how good the heart's functioning, and this is how tight the vessels are. Now, here's what's really interesting about this concept. What's interesting is that there's a concept called ventricular vascular coupling. Take a look at this ASA1 patient. Here I draw a series of loops. Here's your elastance here. Here's your arterial elastance. Notice what? They're like mirror images of each other. And the reason for that is that at that point, they're at maximal efficiency of transfer of the energy from the heart to pump that blood into the vasculature. You want them to match up. Look what happens when we look at our ASA3s, a big hypertensive LVH patient. What happens to them? Well, their arterial elastance is very high in those patients, right? And what does the heart do? Well, it increases its contractility to match it. Notice that the ratio, right? They still keep that mirror image between the systolic and arterial system. The ventricle and the vascular are coupled. So even in sickness and in health, this never breaks. It's something all patients try to maintain. And there's only one thing that really decouples these two systems in current medical practice. Any guesses what that is? It's us. Anesthetics decouple this system. And here's what happens. Here's a normal patient, right? Pre-op. Here's your thing. We've got our elastances, our the nice mirror images. What happens when we give our vasodilatating anesthetics? It may be an epidural, it may be a volatile agent, et cetera, the combination. What happens is the arterial tone drops dramatically. And you can see here what happens is now we have a mismatch between the arterial system, which is low, and the systolic system. We're now inefficient. We're no longer at the ideal. And this makes the heart need more energy per unit of work. And for those of you who don't really follow pressure volume loops, it's really analogous to this model here of car bumpers. Imagine this big SUV is the left ventricle. The back end of the sedan here is the vasculature. You want the two bumpers to line up so we can transfer energy from that sedan into the bumper. What happens under anesthesia is this. You've got this big bumpers up high, and this one's too low. And you really want to get those matched again. And vasopressors are a very good way to restore normal physiology under anesthesia and actually make the heart more efficient. And again, we're not talking about getting this bumper above the other one. We're just trying to restore to a normal physiologic state with vasopressors in the OR to counteract the abnormalities that we've induced with our anesthetics. Okay, and I'm going to wrap up here. We're going to talk a little bit about vasopressors and the kidney. Now, this has been probably one of the biggest concerns about continuous infusions of vasopressors has been their effects on kidney function. To understand this, you've got to go back to basics a little bit. I mean, why are we concerned about hypotension in the first place? Right, the reason is we're worried about autoregulation. All regional systems are autoregulated. When you get below a certain threshold pressure, what happens? Perfusion in that organ drops down. Here's the heart. Here's a kidney here. Once you get below a certain pressure, these organs get ischemic. And the concern was if you get if you get peripheral vasoconstriction, like renal vascular vasoconstriction from vasopressors, that's going to make that worse, and you're going to need higher pressures actually to maintain flow, and those organs could get ischemic. Well, what's the data show? Well, if you gave a direct renal artery injection of vasopressor, what happens to the kidney? It gets ischemic. That's been shown well. But does that model really reflect what we do in anesthesia? I don't think so. As a matter of fact, if you look at some studies that I think more accurately reflect giving continuous infusions at rates of 0.1, 0.2, 0.4 of like norepi, look what happens. Well, it increases blood pressure. That's good. Look at renal blood flow. It doesn't decrease. It goes up. And look at renal vascular resistance. It goes down. Now, why does renal vascular resistance go down with norepi infusion? The reason is by restoring mean arterial pressure, sympathetic tone gets decreased, and the arteries actually dilate. So by getting the systemic pressure up, the renal vascular system actually dilates because of the loss of sympathetic tone. So in this case, you can see renal vascular resistance and flow are improved by vasopressors. Perhaps even more related to what we do is what happens when you give these vasopressors as someone who's markedly vasodilated. And Ronaldo Bellamo has done some really outstanding work to look at this. And let me just quickly show you one of his studies. Here's our control patient. You give him norepinephrine, and you can see a small increase right in renal blood flow. What if we take the same patient and vasodilate them? In this case, they used endotoxin to get a big vasodilatation. Look at renal blood flow. It goes way down. When you give norepinephrine to this vasodilated patient, notice we get a marked improvement in renal blood flow. And Bellamo concludes that this marked improvement with norepinephrine is going to occur in all vasodilated states, including anesthesia. So he really recommends that the kidney function can improve with vasopressors, particularly in hypotensive patients. Now, let's play a little game. Pick your pressure. What's the most common pressure people? How many people use phenylephrine to restore blood pressure? Is that on the cards? How about norepinephrine, epinephrine? Any of those? Yep. Okay. Well, what is really the best pressure to use? Because I know the surgeons hate phenylephrine, and this is a good study. They're going to look at 3 vasopressors. I got them as question marks here. There's the red one, the blue one, and the green one. We use them all to get the mean arterial pressure back up in these dogs who are bled. But look at one of the drugs, this green one, lowered renal vascular resistance the most and improved renal blood flow the most. Any guesses what that one is? I was shocked when I saw this. It's phenylephrine. Phenylephrine was the best. So, you guys, you guys are right. It's really quite a good drug. So you can tell your surgeons that's why you're using it. All right, I'm going to wrap this part up. I just want to say, when you think about regional circulation, one of the regional circulations we're most concerned about would be what? The unborn child, the fetus circulation. Look what's happening in OB practice nowadays. They've gone away from using ephedrine and large fluid boluses, and they're moving towards giving vasoconstrictors to keep the pressure up. Because why? Because that improves circulation the best for the fetus. And this is a editorial by E.T. Riley talking about doing just that, talking about that practice of maintaining regional circulation and the utility of vasoconstrictors. So we're seeing really a consistent pattern across all circulations for that. So I just want to wrap up then in saying, when people think of Connecticut, we're known as what, like a blue state, right? The liberals up there. New Haven hasn't elected, I think, a Republican congresswoman in years. But I think Joe, Lieberman really gives a better model for us in politics and maybe for us in medicine. We need to be conservative in some aspects of our care, and I think the data on fluids, that's certainly the case. But when the BP's in the dumps, it's in recession, you need to give a stimulus, and a lot of times I think vasoconstrictors are the right choice for that. So thank you very much for your attention. Dr. Abernathy, good to see you.